Well, welcome everyone from all around the world. And our traditional greeting for these webinars are good morning, good afternoon, good evening, and good night from around the world. I'm Dr. David Granite, and I represent the World Society of Pediatric Ophthalmology here today, moderating along with Irene Gottlob from England, this incredible panel of speakers that have come together and graciously given us of their time. So I want to get to them quickly and not be on me because I'm not the interesting person. They are. And with that, I'm going to share my screen and welcome everyone literally to the Strabismus Hall of Fame. The speakers that you see today and that will be joining us today represent the keynote speakers who kicked off each and every World Congress. And we will be introducing them momentarily, but these represent 5 of the top strabismus experts in the world and really incredible people who care about this field, who are interested in this field, who have done seminal work in the field, and who will chat with us today about all things strabismus. One note, we heard and got all of your questions from around the world, and they were phenomenal. Literally, we were overwhelmed. In fact, if we played all the videos, there would be no time for discussion. Dr. Gottlob and I will be the ones posing those questions on your behalf. We've got them all written down. We've got, a whole lot of information here that we'll be sharing. And so your questions will be answered as part of this and integrated into the discussion. From a housekeeping standpoint, I want everyone to take a chance and online ask your questions as well. We have the WSPOS Scientific Bureau. We have the Executive Bureau. We have the Connectivity Bureau, in part online with you, interacting with you for an exchange and dialogue online. Maybe you disagree with something you heard. Maybe you agree. Maybe you do it differently. Please enter into that discussion on YouTube and Facebook and post your questions there. Those will be passed along to us and we can engage them with our speakers. We also have Menti questions at menti.com. The passcode is 5912326. And when they ask to enter the code, you put that in. You can also scan this QR code. We're not asking a whole series of strabismus questions, but we would like to know who you are, where you're from, your age, and some basic questions, what you liked or didn't like about our session today. Your feedback helps us get better. As always, when you're a surgeon in the operating room, you have to dispassionately assess what you've done and say, how can I do better? It's the same with these sessions. We always want to get better. We need your input to do so. You will, if you're interested in or need an attendance and participation certificate, send an email to program@wspos.org, and that email will be responded to. It's participation certificate. All questions will be planned to be answered with a PDF afterwards, but the live here is the best way to do it right now. With that, it is my pleasure to introduce my co-moderator, an esteemed educator, an excellent scientist, a doctor of great excellence and one I respect deeply, and who lives in the city of my favorite football team, the Leicester City Foxes, and who will be co-moderating with me, Irene Gottlob. Irene, please take it away and introduce our speakers.
Okay, many thanks, David, for these nice words, and welcome everybody also around the world, wherever you are, in which time zone. And I'm very honored to co-moderate this together with David Granite. So he's professor of ophthalmology at the University of California, and he has numerous, he has written this book, as you can see here, Challenging Cases, and numerous publications. And what connects us, as you already mentioned, is that he is a Leicester Football Club fan. You can see he's all geared up to come as soon as possible to sit in the audience, and I will be very happy to meet him in Leicester. And then actually no one needs introduction here because everybody is known, but I will show one slide about everyone. Can you show the next slide, please, David? So Our first speaker will be Kenneth White. He works in Los Angeles, and he also has his own foundation for to help to treat disabled children, which is really great. He has written, as you can see here, many books and many articles, and he's very innovative. He's world leading on new techniques in strabismus surgeries, and he will tell us a little bit about it later. And next is actually Emilio Campos. Emilio is an old friend of mine. We're very good friends. He's a very acclaimed teacher, and you can see him here teaching at the University of Bologna. The University of Bologna is the oldest university of the world. But you can see also on the right-hand side, he's very relaxed and a very good friend. He has written over 250 publications and books, and is very known and very loved by his fellows. And the next is actually Lionel Cowell. He's Director of Strabismus Services at the Royal Victorian Eye and Ear Hospital in Melbourne, which is the oldest and largest academic ophthalmology department in Australia. He's also very well published, obviously, and known and famous. But you can see here, there's also other talents. He's acting here. This was on a visit to England, and he played Henry VIII at the meeting. And then we have Richard Hurtle on the panel, who is also internationally known. He's known for all his work in nystagmus. He has very innovative methods to diagnose and also to treat nystagmus, and has written extensively about it. You see this book here, but also a lot of publications. And his hobby is actually ice hockey. And I think he's also a trainer for ice hockey. And last not least, Bert Kushner. We all know him. He's a Professor Emeritus in the Department of Ophthalmology and Visual Science at the University of Wisconsin-Madison. He also has written an authoritative book on strabismus and many, many publications. And he is a very sought-after teacher, has many fellows who are now in leading positions, and has an own school of strabismus. And so I will not take much more of your time. And I think Kenneth White, Professor Kenneth White, will start. Can you please start?
Yep.
The format is that every speaker will give a small talk, and then we will kind of have the questions that match the talk or the subject and discuss them in the panel.
While Ken's getting his slides up, Irene, we have people, I'm looking at online, we have people from every part of the world, from the US, Canada, Colombia, Argentina, Brazil, all of Europe. I see England, France, Germany, Turkey, Ukraine, Russia, Spain, Africa is represented. Nigeria is here. We have South Africa is here. The Middle East, Lebanon, Jordan, Israel, Saudi Arabia. We have Asia, Singapore, China, Australia, New Zealand. I hope I'm not leaving anybody out. Jakarta, Indonesia. It goes on and on. The world is listening, Ken, and the platform is yours.
Thank you, David. So I want to talk about divergence, insufficiency, esotropy, which occurs in older people. And it's acquired strabismus with double vision. And before I go into it, I want to talk quickly about a resection and what I developed as a full plication. And my next book on strabismus surgery, I wrote it as a strengthening procedure. And I remember Mark Borchard was a resident of mine at USC, and he asked, how, when you remove a muscle with a resection, do you make it stronger? And I go, you're right. You don't make it stronger, you tighten it. And that's fundamental to understanding how you can use a resection or a full plication for correcting incompetence. You're not making the muscle pull harder, you're making it tighter. And in 1982, I was injecting fluorescein to look at iris angiograms after full plication, and it is a vessel-sparing procedure. I think one of the only truly vessel-sparing procedures. And this is an angiogram showing the inferior rectus, which was plicated. It still has irrigation. And we published several articles. But what about small deviations? And so I developed what I call the central or mini plication. And basically, you suture a small amount of muscle, around 3-4 millimeters, 5 millimeters posterior to the insertion, tie a knot, and then pass your needle anterior, and you plicate the central muscle. We published this, and it works very well for small deviations. You get about 6 to 8 prism diopters for a central plication. And so divergence, insufficiency, esotropia are these older patients. Who's a 70-year-old with an acquired onset of double vision for distance, seeing single at near. And there's been some evidence that it's a lax lateral rectus muscle. And so I thought, why don't we try the central plication in these patients? And this patient has a 16 prism diopter ESO in the distance and 2 at near. So I did several of these lateral rectus central plications, and I had the fellow look at our results comparing bimedial recessions versus the new right central plication, and to see which was better. And these were all my cases. And they were all relatively small angle ESOs in the distance. Now, many years ago, we gave these patients prisms, but nowadays, most of my patients, prisms are not an option because they just had cataract surgery and they're seeing distance and near without glasses. They don't want to go back to glasses. So we looked at 30 consecutive patients, 28 met the inclusion criteria, bimedial recessions, 13 patients, and bilateral lateral rectus central plication, 15. Acquired esotropia, double vision and distance, age 45 years or older, at least 6 months follow-up. And this was published in JPOS, or JAAPOS. I don't know how to pronounce that. Mean ages were very similar. The preoperative deviations were similar. And notice that it was small. These weren't big deviations. They averaged around 14 prism diopters, 13 to 14 prism diopters. Here's what's interesting. Anesthesia, when I did bilateral medial rectus recessions, all 13 were done under general anesthesia, laryngeal mask anesthesia. But when we did the lateral rectus plications, 14 of 15 were topical with a little sedation. So I could do them without general anesthesia. The outcomes were very similar, no double vision, almost, about 90%, and under 5 prism diopters, both groups very good. In one case of the central plication, I overcorrected, but I could cut the suture 6 days later and semi-undo it. We relaxed it a little bit, and then that case did very well. So the central plication is semi-reversible. If you cut it on post-op day 1, you cut the suture, you get complete reversal. But if you wait 6 days, it's interesting. You get a little relaxation of the plication, but it sticks. So similar results in bimedial recessions versus the right central plication. But I like the right central plication. It's minimally invasive. Actually takes me 6 minutes to do the thing. It's crazy. I've changed my technique now. I put the scleral suture in first and use it as a traction suture to put the muscle on stretch. It makes the dissection easier. But on the older patients, there's not much tenons. It's very easy. You only need a 3 millimeter, 4 millimeter conjunctival incision. Topical anesthesia, maybe with sedation, sometimes without. On the table adjustment if you want. I don't do that anymore. Preserves anterior segment circulation. Medial rectus does not. And it's semi-reversible, super safe. You're passing your needle anterior to the insertion. That's pars plana. Even if you go deep, nobody cares. So it is super safe. And I love this for small angles. And here's a picture of Hillary Clinton, and she's got prism glasses on, and maybe I could have helped Hillary. Thank you very much. Oh,
thank you, Ken.
Shameless plug, David. We're doing a seminar on May 1st, Zoom, and we're going to look at atropine, fact or folly. So if you guys want to tune in, you can email me at right2020md@gmail.com. That's right2020md. So there's my shameless plug, David.
A shameless plug indeed. Thanks, Ken. So this is fascinating to me. We published looking at bimedial recessions in these patients. We published and also R&R and a bilateral rectus resection and plication. We've been doing what we found was that if you did medial rectus, you came up short often and you had to increase. If you did an R&R, it worked, but you got an incompetence in this group of people. And then bilateral plications, if you made a mistake, you were overcorrecting. I like the idea of attacking the lateral rectus and doing it in a milder way. I've done your mini plication. I get 6 to 8. I hate your little rhyme, but it's right on target.
If you just need 2, if you just need 2, don't be blue. Follow me. Do the mini T. If you need 6 to 8, don't hesitate. Central plicate. By the way, David, I was visiting professor at Harvard of all places, which probably was not a great place for me to be. But so I did this rap with music at the end. Nobody laughed. It was just horrible.
Well, I understand they invented Boston, so they that's their style. Thoughts, feedback? Any other thoughts from our panel? Bert, if you're trying to talk, you are muted.
Realize I am curious how many people try to identify the cause. In other words, are these sagging lateral rectus muscles, and if so, should they be attended to, and if not, go to the medial rectus muscle?
Didn't matter in my group. I mean, I've been doing medial rectus recessions for them pretty routinely for many years, and I objectively compared the two groups. I think you can do a lot of things to make them better because they have fusion. But anyway, my comparison, it didn't matter. I do not scan patients. I don't do MRIs. Have you ever had an MRI scan? It's horrible. You put your head in that thing.
I've had.
Yeah.
So, but then you don't know which of your patients had lateral rectus dysfunction or not.
I don't even know if it's true that they have lateral rectus. This is what some people have suggested. I don't do MRI scans on my patients. Really, it's torture to go in to do a head MRI.
So that's a great question. With a distance near incompetence, the way you described, that's acquired over time. Do people get an MRI?
David, it's Rich. So we're together to discuss this, and it's 130 years of this type of evidence. There was a recent article in the Blue Journal, and less than 2%, according to Cochrane Review, of our studies are truly evidence-based. So this type of level 2 evidence is what we've been using forever. We have to get better. If we have an idea, a hypothesis, a way of doing things better, I think it's incumbent upon us to teach the next generation how to design clinical trials that really give us evidence, not just things are better. As Ken said himself, they have fusion. So almost anything can make them better. And Bert is right. This is infranuclear. Any lateral plane, lateral, superior, or frontal plane incompetence is usually an infranuclear problem. It's not a supernuclear problem. By definition, that's how the brain works. So the diagnosis, classification, study design, outcome measures, bias, removing bias and confounding are the way to get evidence. I know I've done it myself. I'm not saying that we haven't, but we got to find a way to stop doing this tinkering and say it's science. This is surgical tinkering. I think it's a little better if I do this. It's a little better if I do this, and then you do it and it comes out, so everybody does it. I mean, that's the way we've been doing this for 130 years. And so,
Rich, you remember the optic neuritis trial?
Yes.
It completely threw everybody off. These large studies where you have thousands of patients and you see a vitamin helps macular degeneration, 0.000%, and p-values. A great scientist from Caltech who worked in my office said, if you need a bunch of statistics to prove your point's not very valid. So here's my point. We're in clinical medicine. Both ways work very well. That's important information. We don't induce incompetence. That's important. And also, it's very easy. You can do it without general anesthesia. So you don't need 14,000 studies to tell you can just pinch a muscle a little bit and make them better.
Yeah, but Ken, what you're saying is not that
what you're saying is ridiculous. I'm sorry. It's
but what you're saying
is clinical medicine
better than what everyone else has done.
What are you talking about? Most people do things because their mentor told them to. That's the truth. What I'm doing is comparing people. Rich, what I'm doing is showing a new technique and comparing it to an old technique. Now, there are flaws in any study. We try to make matched groups. But if you think that all that clinical research is garbage and we should throw it out, you're wrong. It's
That's not what I
important.
said.
It's guided us through the years. But I agree with you that anecdotal, I do it this way, or my mentor taught me this way, that's not helpful.
So
But clinical
face-
studies are helpful.
You're trying to determine face validity with a small clinical trial. It's the
What's
parachute.
face validity? I don't know what
I'm
that
gonna
is.
explain.
Face validity.
Face validity is I don't need. Well, that's part of the problem, Ken, is we don't speak the same language. So
Yeah, it's true.
So if face validity is, do I need to study a parachute versus no parachute when I jump out of a plane? No, I don't need to study that, because I know if I don't have a parachute, I'm going to die. And so what we do is say, look, this is on its face, it's valid. I don't need to do a trial. I take a piece of the muscle, I move it over, the patient fuses after. Why do I need to do a trial? And so,
Rich, what if you jump out and you got a big balloon there to land on? You're going to be okay.
All right,
It's
I made my
ridiculous.
point.
I'd like to, I think this is an important discussion, and my position is somewhere in between. I think there's a very important role for things that are short of the randomized clinical trial. No clinical trial is ever going to be done if there haven't been these anecdotal studies first. You're not going to go to NIH, say, I want millions of dollars to test a good idea without any, quote, bad studies backing it up. When I was editor of the journal, I know I probably shouldn't name the specific paper. There was a new surgical technique written up, never described. It's something that I can say every single person to this webinar uses for this indication on a regular basis. The first article ever describing it had an N of 23 cases, which is tremendous. The reviewer I sent it to just sent it back and said, reject it. There's no control group. Now, to me, that was ridiculous. And of course, the paper got published. On the other, so you have to have these studies as backgrounds for doing the randomized clinical trial. But on the other hand, there are limitations with randomized clinical trials. They always answer a question within a good one has a very narrow focus. Does this treatment have a better, let's say, outcome at 6 months compared to something else? Well, that's one question. Maybe another one works quicker. Maybe instead of for amblyopia 2040 outcome, a different answer would be obtained if you were looking at 2020. So you can spend millions of dollars and answer a very narrow question. The original PAT study did not include patients that had verticals. Well, what if you have a partly accommodated VT that has a 2-prism diopter hyper? Can you apply that clinical trial data to your decision making? Technically, no. So there are limitations with clinical trials too. I think that we have to do those for issues that are important, not clinically trivial, and when the difference really is important. But I also think there's a role for these other studies. Now, where we fall down is most of these anecdotal studies don't make any attempt to mask. You can do that on your own. They don't make appropriate attempt to eliminate selection bias. You can do that in your statistical analysis. If nothing else, you can pose the clinical question that you're going to ask, what outcomes you're going to look at. Is it 5 from straight, 10 from straight, et cetera, before you look at your data, so you avoid what statisticians call data snooping, and you can do better studies short of a randomized clinical trial. That's the direction I think we need to go.
I have a question. I have a question for the panel. Why do we operate early for babies with truly congenital cataracts? Craig Hoyt published a paper with like 5 patients, just consecutive group. And for the first time, babies with congenital cataracts got good results. That changed the whole way we treat babies with congenital cataracts. When I was a resident, we were told, don't even operate. There's no way they have foveal hypoplasia. Well, Craig Hoyt with like 5 patients, he didn't even get visions on them. He did it with visual evoked potentials, showed that they could get good vision. So this idea that these clinical studies are garbage or they're not, no, they're very important. And often the N is so small, you can't study them with large studies.
But I also think the problem comes when we have these anecdotal studies with small n's to then make the leap and say, I have shown that X is better than Y. We haven't. We've just suggested it.
Yeah, but may I add only one short point? Is in essence, I fully agree that on one side we should not waste energies and risk for the patient in the moment we want to establish whether a technique is good or not. But on the other side, in the moment that we use completely different approaches and allegedly have the same results, it means that either both work or that both are not right. And there could be a third approach that would be the ideal one. So that at the end, I think it is necessary, if we want to go in a direction in which I hope always we could also always go, is to a standardization of approaches, that something should be done to implement data. Now, this does not mean that I fully agree with Ken, right, saying that I'm not going to do an MRI in all my strabismus patients, but I do need to have it done probably, let me see, in a high myopia, esotropia, where there is a sliding of the lateral rectus. I needed to have it done in order to be sure that this type of elements really take place. Then I don't need to do it later. But at this moment, one could say, and I've personally, for example, done it, that in cases of elderly patient with esotropia and diplopia for distance, with an echography, one can see where the course of the lateral rectus is, and this is not dangerous. And if you see that it's sliding down, you can fix it on the sclera. This I've done it, it works. Now, you could say, it's a third approach, it's a wrong approach, whatever. But at least one has to look in the other direction.
I think this is a fascinating discussion that will permeate a lot of what we talk about today. What's innovation? What's experimentation? How do we move a field forward? Who's the first patient that you do the new procedure on? What do you tell them? I've never done it before. I'm testing it out on you. This is my, these are real questions that we all have to ask, even though it's an incremental change, right? In this example, Ken's done a ton of mini plications, but using it for this indication was a new approach that you innovated. And without that innovation, we don't get anywhere. But what do you tell the patient? And I think this is going to permeate all of what we do throughout the conversation, and I want to keep having it. So with that, in order to make sure that we keep going forward, because I think we could talk about this for quite a long time. Emilio Campos, Emilio, you are up next as our next speaker. Ken, while Emilio is pulling his slides up, there was a question about exactly where you place your suture for your mini plication.
Yeah, let me see if I can open.
Ken, I don't know if you heard me, but that question.
Yeah, I heard you.
Emilio,
you.
One sec while Ken answers this.
Can you
Okay,
see
it's
now? Okay. No, my basic.
Emilio, hold on 1 second. I asked Ken a question while you were getting the slides up. We just want to give him a chance to answer.
You place the suture right, like a 0.5 millimeter in front of the insertion of the tendon. But it's hard to know where the tendon inserts. So I grab the tendon very gently and lift it up, and then I can see exactly where it inserts. So then I pass my suture.
How far back?
Right in front of the
Great.
insertion. So if it's a medial rectus, it's 5.5 back.
And how far back do you tie the muscle for the mini plication behind the insertion?
5 millimeters will get you 6 to 8. So,
Great.
but if let's say I had a celebrity that only had 3 to 4, and so I did 4 millimeters back. But in general, all my first papers is 5 millimeters gives you 6 to 8. But on an individual patient, I will modify it.
There's a question from the public. I guess you answered this already. Do you titrate it depending on the squint angle, the millimeters back?
Yes, but not much titration. It's 4 to 5. If you do less than that, you're not going to get hardly anything.
And more than 5?
So I just modify how far back I go.
What's the maximum?
With the posterior suture, 5 millimeters. That's the most I've done, 5 millimeters.
Thank you.
And what's the width of the plication, Ken?
I use a 0.5 forceps, and I grab the central 3 to 4 millimeters of the muscle, lift it up, and pass my needle underneath my forceps.
And 6-0 vicryl.
Terrific.
I use 6-0 vicryl.
And you do 2 passes through the muscle?
I do 2 passes. I do 2 passes and then tie a knot. And the reason for that is that if you tie a knot, you get a fixed loop, and the muscle fibers or the tendon fibers can slip through it. If you do a cinch, then you really tighten those muscles and you don't let go. So when you tie a horse up, you use a cinch, not a knot. But if you're coming off a cliff, you want the bowline knots so that you want a fixed diameter. It doesn't strangle you. I don't know if that makes sense. But when you tie a knot off, square knot or a bowline, you have a fixed diameter of the rope or suture. I want a cinch, so I do a cinch and a knot over it. That's a very good question. Thank you for that question. That's a very good question. And by the way, if you retrieve a lost muscle, don't tie a knot. Do a cinch and then a knot over it, because you'll pull on your suture and you'll have a nice ring and no muscle.
Terrific. Well, along the lines of what we've been talking about, I think Emilio's talk is timely in the middle of this session. Emilio, you're up.
Yeah, thank you very much. And I have to, at the beginning, really congratulate you and Ken Nisher for having been able to pursue and strengthen this initiative of putting together all people interested in strabismus in the world. And this is the only organization which does it effectively. And I think you have really, we owe you a lot. So that's something that I couldn't avoid saying. As much as you can be like it or not. My problem has been for a long time, having dealt with strabismus almost 50 years, that it is impossible to obtain a standardization of approaches for the result, because the result is both anatomical and functional. So that a lot of people, as we discussed also a few seconds earlier, say, I have a new technique, the other one says has a different technique, and everybody speaks on different approaches to be used with measurements or other type of tables or calculation. I don't think that this type of system should continue. And I think that one of the tasks that this group can be taking on itself is really, for example, as the following. We are speaking of standardization of techniques. How do we, does one surgeon act? How do different surgeons act? And very simply, how do one puts the suture on the sclera, on the needle holder? How is motility tested? All this type of thing probably, in my opinion, could be improved only by creating a series of video libraries available to all over the world, in which really it is clear how and how correctly we should do this or that. We just heard Ken Wright saying, I put 2 millimeters my forceps, and then I put a cinch, and then I move this. This is very clear what he says for somebody like him, who is an excellent surgeon and can tell you about this. But somebody has no idea of what we are discussing would have it extremely better if this could have be put on a video, and the video should be then circulated as much as possible. I think that in this direction we should go. We should go in the direction of how we put a needle on the sclera, in which direction, how deep it is, how length is the passage, how, as we said before, the needle holder has the suture on it, how much muscle is taken in the suture, because obviously, as you know, on one side, the more muscle you take, the safer you are. But the more muscle you take, the less effect you obtain if you weaken a muscle. And then there is another issue that I just want to throw on the table. Is personally, I've moved for the last 14 years totally to microscope surgery for strabismus. And really my life has changed because I can see much better all aspects which then could be otherwise erroneously by myself made. And so that I strongly advise everybody to use this type of approach. Now, the next point is that it is impossible, as people say on the basis of tables, I have so and so amount of angle in this position of gaze and so on, and therefore I will do 1 millimeter or 2 millimeters recession or a section of duplication. This means nothing, because it is impossible that the same person does always the same. It's even more impossible that different surgeons do the same. Now we have, on the other hand, something which can help us. For example, typically, the fusion. Motor fusion is something which helps us to keep the eye parallel, even if they are not perfectly aligned. And so that we have really to spend energy in evaluating whether this fusion amplitude is existing, whether it's efficient, whether there is diplopia, and the age of the patient is also most important. The age of the patient is important because the more the patient is elder, the less fascia exists, and therefore also the effect on suture and muscle on the sclera can change. Finally, something that people don't talk very often of is the fact of whether there is, in cases of infantile strabismus without normal binocular vision, free alternation of fixation and or amblyopia in one eye. These two elements will have a great influence in the final results, and especially on the duration of the effect of our surgery. And all this should be, in my way, put in a box and checked and done and repeated every time we have to do with a different patient. Now, in the moment in which we talk of concomitant strabismus, also here, we should not be always doing the same type of approach, but the important issues are evaluating obviously motility, psychotic velocity, force action, and then obviously reinforcement have no meaning in the moment in which we have a strong contraction or overaction of the antagonist of a muscle. And reinforcement of a muscle itself is also without of any interest in the moment there is no residual function whatsoever. And obviously a transposition should be done. Finally, in mechanical strabismus, which is now more and more seen in cases of high myopia, which, as I pointed out before, in cases of thyroid eye disease, in cases of trauma and the like, only by eliminating the obstacle we can obtain an improvement. Making other type of approaches is only a creation of an iatrogenic type of condition. The same which will happen, for example, in the standardized approach for infantile strabismus, when I, for example, do in an isotropia by medial recession, and there is still an angle, and automatically I do application or a resection of the lateral rectus, when there is still a strong overaction of the weakened muscles. So I just create an esophthalmus in those patients, and I do not improve motility. So my issue is, and my idea is to examine patients as much as possible from various aspects, not fix ourselves like in all charts is still seen on several numbers with angle measurement and so on, without having information on motility. And second aspect, trying to be as repeatable as possible for ourselves And specifically in the moment in which we are proposing something different to somebody else, we should be totally capable in transmitting what difference is in our approach, both technically and from finalization as compared to what is available till that moment. Because otherwise, strabismus surgery will remain an art and they will never become a science. And as I pointed briefly out yesterday in the practice meeting, I think that we go on PubMed and look for strabismus papers. The amount of papers on this subject is extremely limited, with age factors limited, citation and the like. Thank you very much. And hopefully I did not override my time for this presentation.
Thank you, Emilio. So, but the question is how to achieve this. So we need enormous amount of data to put together. Can I ask maybe the panel if AI would have a role here? Or how can you? I mean, I agree. You know, everybody modifies the surgery probably, but it's
my idea is really that a group like the one led by David Grant can start creating a database on which everybody is trying to put together many elements. And from that, try to concentrate and arriving to some points in which people coincide in their opinion, and then slowly, it will not be solved in one day, this problem. But I think it could be at least a task that as a group with interest in strabismus will have to offer a next generation.
I wanted to just lay out 2 points because, Emilio, I think this is fascinating discussion. Rich Hurdle and I published 25 years ago psychotic velocities after recessing a muscle. And I'm sure Rich remembers this. It was presented at the combined ISA-APOS meetings. And we also looked at when we recessed the muscle with an adjustable suture. So now you have a contractile element attached to a non-contractile element attached to the globe. And that eventually the suture dissolves, so it changes over time. And what we found when we recessed the muscle is the psychotic velocity didn't decrease. So as Ken Wright was mentioning, where he's talked about tightening a muscle versus not as a strengthening procedure, recessing the muscle isn't necessarily a weakening procedure in the sense of that you can still generate the same psychotic velocity. And the other article that we published was we examined 88 specialists, orthoptists and pediatric ophthalmologists, and had them measure me and say, put my head in the different positions. And there was no agreement. I mean, when people were just doing the simple measurements, we couldn't get agreement. So if Ken Wright says for superior oblique palsy, if you see in contralateral gaze more than 15 prism diopters, we haven't even defined contralateral gaze that everyone measures the same way. So how do we apply information that we get from the literature, from one doctor, from one expert to the next, if we're not including that? And Bert, I raised this to you years ago as one of the editors of a journal.
But I'm sorry to interrupt. I just want to say, I fully agree with what you say, but this is the reason for which all the data written in the literature make no sense whatsoever as far as numbers are concerned. And that's why my idea was to offer the opportunity of showing the approach used by the single examiner in order to achieve that number. And with a video, probably I could do it.
Just 2 quick comments. When I first started doing strabismus surgery, I wore loops that were, I think, 1.8 or 2x power. And when I subsequently looked through the microscope at a colleague's suggestion, I really appreciated the increased magnification. But by that time, my practice was so much re-ops and complicated cases that the microscope limited my ability to look from different angles in ways that I was used to. I started using 4.5x loops. And I think that's a very good compromise between a microscope and the standard loops. It's kind of like a head-mounted microscope. It gives you the magnification of a microscope and the mobility of loops. And I personally recommend that to people. I think the points Emilio raised are all excellent. I personally think that the next major leap in our understanding of strabismus and improving results is going to lie in a slightly different direction. I remember the first time I did a retrospective review where I generated a dose response curve for my surgery. This happened to have been esotropes. And I noted there'd be, let's say for all the patients that were 30 prism diopters, I did the same operation. And there's one patient I got a 40 prism diopter effect, overcorrected. Another, I got a 20 prism diopter effect. And I think our next step forward is going to lie in determining what's different between those two patients, assuming it's not surgeon error. We don't look really at length tension curves and muscles while we're doing surgery. That has only been done in laboratory settings. The answer may lie in there. It may have to do with variations in anatomy. That's not really looked at. I think that what the variables are that make different patients respond differently is the direction that we really need to look.
Hey, Bert, I agree with you. One additional thing for the loops, use the Keplerian, not the Galilean optics. If you get one with the Keplerian, they're a little longer tube, but you can get the whole face. So a 4X with Keplerian, I think is as good as the microscope in my hand. I love it. I agree with you. I think especially on re-ops or we have to do multiple muscles. And the second thing that really to try and advance the science of strabismology, we need to understand as a group that, and maybe we should get help from neurology, that we're operating on the brain. Yes, the muscles are being moved and there's definitely infranuclear components, but I think we teach strabismus and we begin to understand the most of us from the eyes up. It's taught from the eyes up. John Flynn, God rest his soul, would make his fellows do neuro-ophthalmology and pediatrics. And I think that it's a fundamental conceptual change in teaching strabismus from the brain down. And I think that the characteristics that make up the brains of these patients will add to the variables that you mentioned, the infranuclear variables. And we can't ignore those supranuclear variables because I think that's where some of the variability in our approach to the outcomes of surgery exists.
Terrific. I think that as I thought this was going to permeate the entire discussion, we want to move on to our next speaker, and in timeline chronological order, that would be Lionel, who was the speaker at the World Congress. While Lionel's pulling his slides up, I'll just add that Rich, I recently, like 2 weeks ago, got the Keplerian loops, and they're actually zoomable, that I can go from 3 to 5x, and they have a built-in headlight. So I feel like I do have that portable microscope that Bert was talking about, and it's been a fabulous advance for me. Lionel, it's all yours.
Can you see my slides?
Yes.
Good. Wow. Ken, I'm going to present an anecdotal series of patients. Richard, get your gun ready. I'm going to talk about
fire. Don't worry about it.
I'm going to talk about bimedial elevation as part of the treatment for convergence insufficiency. The patients with convergence insufficiency that come to surgery are a very difficult group of patients to make better. And there is a large number of different surgeries that I have tried and you have tried, and none of these have got very wide acceptance. I beg your pardon? I beg your pardon? Sorry.
Lionel, can you go to slideshow? Right now, you haven't put the slideshow on yet. We can see your slides, but they're not on slideshow, like you would be presenting at a meeting. The normal slideshow, just the way you presented any meeting, you would have to put your slides on slideshow.
New
Thank you.
slide.
Yes, perfect,
That's better now.
perfect.
So Ed Buckley, 17 years ago, in a textbook, suggested this treatment for convergence insufficiency. He writes, I have used supraplacement of the medial rectus muscles, plus or minus small resection, with some success. In essence, these patients are being treated as if they had an A pattern, and supraplacing the medial rectus muscles helps create more of an effect on down gaze. And I'm grateful to Bert, who directed me to this approach. And now I'm having, and this is from Bert. For an A pattern, one typically elevates the medial rectus in both eyes by medial elevation to decrease convergence on up gaze, but bimedial elevation without an A pattern is likely to cause a V pattern. So I have done a number of cases of LRSS for the distance exotropia and bimedial bunch up and elevate to the upper pole of the insertion for the near component of the convergence insufficiency. And I'm going to present 8 patients, and in 6 of them I did both the lateral and the medials, and as you will see, the results are pretty good. So this is the near exotropia results, and you'll see a very large improvement and asymptomatic outcome in 7 of the 8 patients, and similar outcomes when I do the LRSS for the distance exotropia. So this is a study that has many limitations. It's a pilot study that I think demonstrates that the technique is safe and effective. And I'd like to commend this operation of bimedial elevation because it seems to usually compensate for the CI component of this difficult condition. And I propose it as a sensible, simple intervention for a sometimes difficult problem. Thank you.
Lionel, just a question, if I may. Are you saying the way you do this procedure, it decreases the distance near difference, or are they asymptomatic at near because you've induced a V pattern and that reading and down gaze has a V? When I do this, I get 6 to 8 prism diopters of induced V.
Yes to both proposals, to both of your things, and it's a small V, which is sometimes measurable and sometimes not measurable, and improved reading. Mm-hmm. So I think, and sometimes the V isn't measurable, but the patient will tell me that their reading is better on down gaze, and they return to their old multifocals.
Mm-hmm.
Bert, you've done some work with the slanting of muscles, and people have recommended slanting of muscles, various different muscles for this procedure. And in the arena of we don't have large randomized clinical trials, we have to help the patient who's in front of us today. There's an old saying: the plane takes off today, even though 10 years from now it may have better safety precautions. But we do have to take care of people in front of us today. Comparing what Lionel just said to other approaches, what are your thoughts?
Yeah, when you say I've done work on slanting, it's mainly been writing that I don't think is a good concept. I don't do the procedure, haven't done the procedure. I'm possibly modulating my feeling about that somewhat. The idea of slanting, if you look at the literature, it's interesting due to some early investigators misinterpreting some basic physiology that Alan Scott wrote. People would slant in opposite ways for the exact same procedure. In other words, for a convergence insufficiency, some people would slant the superior pole back and others would slant the inferior pole back, and both reported good results. And I think it probably worked in spite of the slanting, not because of. However, some of the newer work that Joe Deemer has done about compartmental innervation may explain this discrepancy, and it's a little too complicated. It would take up too much time to go into detail here. But what to me is most relevant, and I think this is widely overlooked, we use the term convergence insufficiency to describe what I think are two different entities. There's the fusional convergence insufficiency. That's a patient with a trivial exophoria and decreased fusional convergence amplitudes. That's the young patient that we do orthoptic exercises for, which I believe do work. The adult patient that has a true exotropia at near and a smaller but exotropia at distance actually has decreased accommodative convergence. They may have normal accommodation for age, but if you rigorously test their ACA ratio, you'll see they have often ACA ratios of essentially 0. And that's why I think that none of our procedures will predictably eliminate the distance near difference, because none of them really address the ACA ratio. I think the very popular approach of recessing the lateral for the distance angle and the medial for the near angle, I think people are just massaging numbers that way. I think it's been shown that it's not true that the lateral affects the distance deviation more and the medial affects the near deviation more. Steve Archer is probably most responsible for calling that to people's attention. I think that formula basically has you operating for something that's an average between the distance and near deviation, and how you split it up between the lateral and medial is probably inconsequential. So I think this is a very difficult entity to treat. And I, near the end of my surgical practice, was doing not exactly what Lionel described, but what Ed Buckley described, transposing either the laterals or the medials up or down, depending whether I'm recessing or resecting, to induce a V pattern, which helps with reading. And I think that was more effective than actually collapsing the distance near difference.
Ken, you and I live in California in the United States, where people do not want to wear prisms, right? They don't want to wear glasses. They don't want to wear prisms. They want to be outside. They want to play. What do you do when someone with convergence insufficiency comes in? And, you know, given the fact that we don't even have a standard definition for it, we're going to have to assume that we all know what that means. So how do you approach this?
Yeah, I think it's difficult. I don't know of a good surgery for it. I was in India, and they presented a great result in the chemistry professor who had significant convergence insufficiency. And I remember they bring him out, because I told them I don't operate for convergence insufficiency. I give them prism glasses. And they bring him out and say, well, Dr. Wright, you don't know what you're doing. This guy, we operated, he's chemistry professor. We operated, he did great. And they have him up close and he's fine. And I asked him, look in the distance. And he had double vision every time he looked in the distance, and he put on base out prisms for his ET in the distance. So I don't have a good answer for that, David. What you really need, I guess, well, here's what I think. I think you really need is stronger medials. And I agree with Bert, you need to change the ACA ratio. So how do you make a medial rectus stronger when they look up close? And the only way I know is to inject them with xylocaine, inject the medials with xylocaine. First you get paralysis, but then you get hypertrophy. So maybe one day we can actually make muscles stronger. And you make structural muscles stronger by breaking them down, and when they reorganize, they hypertrophy. So I don't know, might be an electronic way we can make muscles stronger. But right now, I don't have a good answer. I give them prism glasses, and it's really a problem in Parkinson's disease. Patients with Parkinson's really have a high incidence of convergence insufficiency.
I don't think it's actually a weakness of the medial rectus. They don't tend to have an adduction deficit. It's up in the brain. It's whatever mediates the ACA ratio. They don't get accommodative convergence, which is different than saying the medial rectus is weak.
I'm not saying it's weak, Bert. What I'm saying is a way to make it better would be to increase the medial. Now, your risk is you're going to make them ET in the distance.
Yeah.
But the medials are relaxing in distance vision when you look in the distance. So you should get, if you make them stronger, preferentially a better improved results up close. But you're right, when you look to side gaze, it might induce incompetence. I've never done that. I'm just saying, I'm trying to think of a different approach. But right now I don't operate on convergence insufficiency. I do pencil push-ups, and in the older patients, they don't work.
So the last 15 years of studies by the CITT group has shown how to make the brain better. Whether or not that technique is applicable in all frontal plane incompetence in which the near deviation is greater than the distance deviation is yet to be tested. But what it has shown is that we can change the midbrain, the cerebellum, or its connections to get to what Bert has said, which is not only the ACA ratio, but the CAC ratio, which is also responsible for distance near frontal plane incompetence due to nuclear, paranuclear, or supranuclear problems. So we do know how to make the brain better. It's been proven in the kids who have, as Bert said, typical childhood CI. But positive fusional divergence increases, the amplitudes of accommodation increases, and the combination of those two decrease the ACA ratio. I'm not sure yet how to apply that. It hasn't been systematically in the adult population who have fusional potential. And I think that's different than the group of patients who clearly have a mechanical frontal plane incompetence. Patients who've been operated on for strabismus and now have near greater than distance or distance greater than near, where you do have to actually do some surgery to try and to get them to have now frontal plane competence, whether they're ESO at distance and near or EXO at distance and near. So I think there's a bunch of different patients in this group too, that need to be defined and classified in order for us to understand how to treat them, either medically, surgically, or medically.
Yeah, may I add one thing? It was pointed out before that moving up or down the medial and lateral recti, because this was the original operation suggested by my late teacher Bietti in the late 60s. It's something that is really not clear, and I think that a good point was made by Rich, saying that the whole system in some way changed. Because I very well remember when Bietti made us do this procedure in V pattern and shift the medial recti down and the lateral rectus up. Then came a certain Dr. Boyd, Alistair Boyd, who a couple of years later described the same operation. And again, not offering acceptable explanation. I think that only Bart has done an extensive study in which he compared the various types of indication for this procedure. But generally speaking, probably a rearrangement of the neurological organization, as Rich has proposed, is the one thing which makes more sense.
Well, this is again terrific discussion. We knew that on any one of these topics we could spend 2 hours. As Ken Wright pointed out yesterday, each one of these topics could go on and on and on. But we want to make sure that everyone has a chance to present their short presentations and then a longer discussion. Next up will be Rich. And while Rich gets his slides up, Lionel, did you have another comment?
No, that's fine. I just want to make a plug for bupivacaine injection to medial rectus as well. there have been a small number of anecdotal series, all small numbers, and that also seems to be effective. So I accept every positive and negative comment that's been made about my presentation, and I think this is something that requires a more scientific evaluation, one that will satisfy Richard's criteria.
Yeah, one where we start with what is convergence insufficiency.
For example, yes.
Yeah, Rich, the podium is all yours.
All right, I'm assuming you could see the slide okay. Does it look all right?
Yes.
Okay. So what I'm going to talk to you about now is my understanding of what it means to have a head posture associated with nystagmus. Here's a little girl up on the left that's turning her head and turning her eyes so that we think she can see better. And we think that the two are directly related in a causal fashion, not just temporally related. And so over the years, my understanding of why patients position their heads has changed. Not only why they do it, sometimes why they do it intermittently, and what happens to the head posture after surgery. And so I'm going to share with you that via this slide here. The clinical head position is really the consequence of a constellation of a large number of factors related to the nystagmus itself, and also factors related to non-nystagmus factors. And I'll go over how each one of these and how you in the office, without any fancy equipment, can determine which factors these patients have or don't have. So for instance, if they have a position in gaze where the nystagmus is least, if they look to the right and left of that position, they'll jerk right to the right of it and left to the left of it. And that area in gaze the nystagmus will be least. That's called the neutral point. If they have a position at near where the nystagmus is least, then if you ask them to look in the distance and then quickly look near, distance near, then the nystagmus will obviously change in intensity, amplitude, frequency. You could do this also with base out prisms if you want to do a step response, but distance near works fine. Do they have those are the static reasons that the nystagmus gives you a changing head posture, because if I'm converging, I don't need to posture my head. My head can be straight. Dynamic conditions that are associated with the nystagmus, including the fixing eye. For instance, if I have a latent component to the nystagmus, whether it's infantile or fusion maldevelopment, if I fix with the right eye, then the eye is going to be in adduction and I turn my face to the right. If I fix with the left eye, then the left eye goes into adduction and I fix with a left turn. So the reason my head is going back and forth is because the strabismus may be intermittent and break down, and fusion breaks down. And as soon as fusion breaks down, the latent component comes out and they change their head posture. There's also a dynamic head posture change associated with the stimulation of smooth pursuit, vestibulo-ocular reflex, or the OKN. The null position, a static null position, will change and move with the pursuit stimulus in the opposite direction. In other words, if I see something pursued moving to my right, then the null position will go to the left. And so my head position will go in the direction of smooth pursuit. And this is the same for the VOR and the OKN. There's also 17 to 33% of patients with infantile nystagmus will have a period where the nystagmus changes in intensity and or direction. This is called periodicity or aperiodicity. And the easiest way to check for this is to cover one of the two eyes, and in patients with strabismus, cover the non-preferred eye. Ask them to look straight ahead for 5 minutes, and you can videotape it and then speed up the videotape. That eye should have a stable, no matter whether they're in their static null position or not. If they're looking straight ahead, they should have a constant amplitude and frequency, unless they're falling asleep, for the entire 5 minutes. If the nystagmus with the fixing eye and distance straight ahead changes in intensity or direction, they're more than likely to have some periodicity or aperiodicity to their nystagmus, which also influences their head posture. For instance, if the nystagmus changes in intensity and always is jerk right, they're going to have a right face turn when the nystagmus increases in intensity, and when it goes to their baseline, you won't see that. Now, there's non-nystagmus factors for the head posture. Certainly, the vision changes it. If I have really poor vision, I'm not going to use an eccentric null position. I've seen this in many patients, correlated it actually, patients who are pre-ambulatory and are using a head posture are more likely to have better than 2100 vision when they get older. Do they have an associated strabismus? that determines whether the head is postured or not with each eye that's fixing. And recently a study we've shown, and this is in the Journal of APOS in Press now, and you guys can do this yourself. There's something called egocentric localization or allopathic localization. Egocentric is the relation of the body to objects in space or in your environment, and allopathic localization is objects in relation to each other outside of your body. And these are central processes that involve the parietal occipital lobe, as well as the cerebellum and brainstem. And these are wired in when we're very young. And if you take one of your nystagmus patients with an eccentric head posture, and they've had it for more than a year or two, and straighten their head, physically straighten their head to the zero position, and ask them if their head is crooked or straight, almost 80% will say their head is crooked when you physically straighten their head. They've had rewired egocentric localization, which contributes to sustained anomalous head posture. In addition, neuromuscular abnormalities, asymmetric in the neck, also contribute to sustained asymmetric, sustained head postures. So using the position of the head as a pure outcome measure for interventions on the eye is really confounded because of all of these factors. And now all of these factors you can determine yourself clinically. And so you can determine which ones are the ones that are contributed to the head posture by the eyes and why. So if the patient's still posturing after you've done eye muscle surgery, say, for a head posture, it's probably due to some other factor. That's not because you didn't do enough surgery or you did the wrong procedure or you need to do more surgery. The point of this is to understand that the head posture associated with nystagmus is a complex combination of dynamic and static nystagmus factors plus non-nystagmus factors. That's it.
Okay, thank you very much for this overview. So how does this influence actually practically what you do?
I'm sorry, I didn't get the last part of that, Irene.
So I understand it. So how does this influence practically the amount of surgery you're doing?
So that's a whole different question on what's my approach to eye muscle surgery in patients with an anomalous head posture. Is that what you're asking me?
Yeah.
Yeah.
What's the connection between diagnosis of static and dynamic and what you, at the end, what you decide to do for surgery?
Yeah, so my approach to eye muscle surgery in patients with nystagmus has been outlined in detail in multiple publications and in the textbook, and it's probably too much to go over in a short question like this. So, but what I have done is published my approach to eye muscle surgery in patients with nystagmus in a 9-algorithm nystagmus surgical technique. So I've written in detail there what has to be done, and it's not just the head posture. So other things are taken into account. So the 9 surgical algorithm that I've published in the past is the framework that I use for treating patients with nystagmus with eye muscle surgery. And that's available.
Rich,
it's available, easy to get.
Rich, one of the comments that came into us, in fact, we got a lot of these questions that were sent to us ahead of time, was about the tenotomy with replacement for somebody without a head posture and without strabismus, which I think represents less than 10% of the patients that you see with nystagmus. But additionally, comparing that to this newer procedure that's been proposed, which is a myectomy and then attaching those muscles to the pulleys that Joe Diemer has described, as well as large retroequatorial recessions. So if that can be done quickly, about commenting about those things, it would be great.
So every time you operate on the eye muscles of patients with infantile nystagmus, it makes their nystagmus better. I'm going to say that. It does. It makes it better. So which operation you choose depends on what outcome you want. So if you want to make the nystagmus better, the more that you actually cripple, the more the nystagmus will improve. And I think some of the retroequatorial recession as well as the myectomy are attempts not only to reduce the nystagmus, but also physically reduce the either length tension or the neural impulses or the actual mechanics of the action of the muscle itself. So I think that depends on what your goal is. And if your goal is to limit ductions and limit the eye muscle action itself, in addition to the nystagmus, then the larger operations are more effective, obviously, because the standard eye muscle surgery that we use, and I use standard eye muscle surgery for nystagmus, is an attempt to do that without limiting ductions or without limiting the function of the muscle. And so I think that's where they differ. That's where I think the philosophies and the approach differ.
May I ask you just shortly, do you see a major difference in results of whatever approach you use, in which you dampen in some ways in nystagmus, in patients with different visual function?
So, yes, it depends.
Somebody who reaches a higher acuity.
So I think that using visual acuity as an outcome measure for intervening in nystagmus is fraught with difficulties and has to be approached very carefully. We don't use visual acuity as an outcome measure in strabismus. We don't use it. We use eye muscle and motility outcome measures. So, but I do use I do report visual acuity. I study it. I do report visual functions before and after eye muscle surgery. But the one that I think is the best visual function to use is clinically on a routine basis is contrast sensitivity, not letters on a black screen. Black letters on a white screen are a measure of visual function that may or may not be related to the nystagmus. So you can measure a patient with nystagmus's visual acuity, depending upon how you measure it and when you measure it. They have a dynamic visual system. Their visual system from a sensory point of view is dynamic. It's never the same. So they have a variable measure of visual function. If I measure them and make them mad, their acuity is worse than if I measure them and they're undergoing mindfulness meditation. If I measure their visual acuity under the effects of Valium versus they're seeing their girlfriend for the first time or boyfriend for the first time, then they're going to have different visual function. So saying what their vision is as a static acuity is really not representative of how the visual system functions. So I use dynamic measures of visual function to show how changing the nystagmus changes their visual function. And that's gaze-dependent visual acuity, visual reaction time, contrast sensitivity, vision as a function of gaze. And you can do this in your office very easily. Take the patient's head, turn it to the right and to the left, or out of their and in their null position and at near, and measure those and write those acuities down, and do that before and after treatment. And you'll see that there's some changes in that. You can do that also if you get them in the right emotional state. Certainly in the office, I'll take patients who are doing this with their head and then straighten their head or go in the other direction with their families there, showing them how the visual system can change out of their null position as well. So I think it's a complicated question. It's really complicated. And I understand that. We're so used to doing this and checking vision and doing this and checking vision. But that's not how these patients function. They function binocularly. They function with both eyes open. So binocular acuity is also a very important outcome measure. And I've been around the world and helped with patients all around the world. And the first thing I said is measure their acuity with both eyes open. It's very important. I've seen patients, many patients with albinism who are 2200 and then both eyes open, they're 20/70. And it's never written on the chart. It's all you see is 2200 in each eye. You know?
I fully agree.
I know it's a long answer, but
no, I fully agree with you, and I would like to add also that one system also for this patient is to measure with both eyes open visual function, having homonymously based prism in front of their correction, and see how by changing the position, acuity changes.
Yeah.
Yes, I think it's obviously very nice if you can measure dynamically and in different positions of gaze. I just wanted to say, so I think Kestenbaum procedures is really very, very good. I mean, patients are very happy. So I just looked at the series of my patients, and I think 1/3 gained 1 line with binocular vision, just in the null point, whatever, with a free head position. And 10% gain 2 lines. So at least that's a very good result. And many say subjectively they see better. So it's a very good surgery. However, I tried actually in 12 adult patients, and it might be different in children, to do just, disinsertion and reattachment. And these patients, for me, didn't have any results, neither subjective nor objective results. And we did very well controlled eye movements several times in this patient beforehand and after the surgery. And we couldn't really find any improvement in those patients. And these were adult patients without squint correction, just reattachment of the 4 horizontal muscles.
Can I make a
I
question?
don't know what to tell you. Yeah.
Can I make a comment on face turn, David?
Okay.
Yeah. So when you teach residents and even fellows about face turns, it's quite confusing for them. So what I've done is, instead of saying face turn, gaze preference, because that's really what it is in terms of ocular torticollis. So if they have a left gaze preference, test Kestenbaum, you move the eyes here. So I don't say face turn anymore. I use the term gaze preference. And then finally, I want to make a comment. I did retroequatorial recessions of 4 horizontal rectus muscles many years ago, and I didn't see much change. In fact, Mark Borcher and I did eye movement recordings, and initially you do have some result. Then over time, the visual acuity did not improve. And I reviewed some of the original studies on retroequatorial recessions, and their average improvement was 1 line, and they were not masked. They weren't even a comparative group. So, my experience with just retroequatorial recessions, that I didn't see a great improvement in vision.
Yeah, I agree with
in binocular vision. And I'm always test binocular vision in nystagmus patients. Always do that.
I also did reequatorial recessions previously, and I have given them up because there was not enough improvement.
So I would really encourage all of you who do any of this to not use Snellen acuity. Start doing contrast sensitivity.
But we're speaking also about subjective improvement.
What contrast?
What
contrast?
Right after surgery, usually they feel better, and after a year, they say everything, all the effect is gone.
Yeah, I agree with you 100%. Initially, you'll see some, but not long term.
Richard, what contrast test are you using? Using 10%
I have 2 or 3
contrast?
commercially available ones in the office that I use, and I also have a computer generated one for the data that I use to publish with. So their light box, 2 of them are just standard light box, commercially available. I can send you which ones they are. It's quick and it's easy, and they get better. I plot them out. I don't know what to tell you. I'm always confused when I do 5 nystagmus operations a week. Now it's from about 80 countries, and I've done thousands of patients, and I've been measuring them for 15 years, and they see better, they function better. And it's always interesting to me that I hear that these patients don't do well in other people's hands, and I'm not sure how that's different. I mean, I'm publishing all the results. I work with people that these families come from all over. If there was some bias or that really wasn't helping them, then I think I would have seen something. I'd be stopping doing. So I'm always a little confused by when I hear that other people who operate for patients with nystagmus that they can change their head position, but nothing else improves. I would like to spend time with those patients, look at them, look at their data. Like, for instance, Irene, I would like to look at the data and the patients that you did tenotomy alone on, and see maybe some of them actually did get better, but the visual functions besides acuity were not measured. Their foveation periods, what did you measure foveation? And I'm not trying, my point is that it's interesting to me that I'm the only one in the world, it appears, where the nystagmus patients are getting better. I don't know. And I'm not doing anything that's different than any of you guys are doing. So I don't know how to resolve that. And we're talking in this, I don't know how. I know other people do nystagmus surgery, and I've heard from people around the world, many people in India and Asia and South America, even in Canada, that when they do the procedures, the patients are better. But when we get into panels like this, I hear that the patients don't do better. So I'm always confused, but we have a panel of experts together.
Well, Rich, many patients do get better. You personally have helped me for 20 years plan a surgical recipe for numerous patients, and for which I'm very grateful. Thank you. Many patients get better, and a small number of patients get a lot better.
Yeah.
And that's terrific. I'm interested in your egocentric patients, of patients who have a face turn that is not improved a lot because of their egocentric issues. Is it, do you see no improvement, some improvement?
Yeah, good question. So the patients who have persistent anomalies in egocentric location or neuromuscular or both usually wind up within about plus or minus 12 degrees of straight, but they still have a small posture. There's definitely a significant improvement. So what sparked my interest in this was that the 40-degree anomalous posture went to 10, but when I measured the null width with eye movement recordings, it was 25 degrees. There's no reason they should posture their head. The null position is 25 degrees wide. So I straightened the head and they said it feels crooked. And so their natural position now is 10 or 8 or 9 degrees. So there definitely helps them. But it's the reason why, I think one of the reasons why in many patients, we don't completely straighten the head when we do eye muscle surgery. And that was the point of all this. The expectation that the head will be completely straight when the patient's in their rested or normal position can't be blamed on the eyes after a while. The eyes may initiate the head posture, but they're only responsible for part of the head posture if it's chronic.
Could this be age-related? Are you seeing this?
Yes,
in patients?
I think time and age, yes.
So
Yes, the babies
patients
don't do this. If I do that at 12 to 10 to 14 months of age, the kids with albinism who are doing this all the time, they don't do any of that after I'm done if they're 12 or 14, 16 months of age. It's the older kids. It's the kids that were told to wait till they were 10 years old to do AKs on, that it doesn't ever completely get better. And they've had them since they had neck control at 4 to 6 months of age. They've had a head posture that they use intermittently. Because remember, the child is forced to make a decision with an eccentric null position. They either see better or feel better, see better or feel better. And most of children will choose to feel better. So they only do this, when they really want to capture something or the board or, again, something of interest, it sparks them in the distance.
Rich, I can remember one patient I saw that I thought did not have a null position because he just would never adopt it. He would never adopt it. And it took me a long time to find it because it was in such an extreme position. And the null position can be anywhere 360 degrees around the head.
Right.
I like this conversation.
Correctly. Right.
Yep. This conversation has been great. And Irene and I let it go on longer because we got our phones and YouTube and the chat groups lit up with questions about nystagmus. And you were answering all of them and discussing them right here. So we let that go. To alert everyone, we're going to be going probably close to 2 hours to finish this up because as we guessed yesterday, this conversation can just go on and on about any one topic. And we can go in depth on any of them. So with that, next up is Bert Kushner to give our last short discussion and last short presentation with what will likely be a long discussion.
Okay. Can you see my slides, my screen?
Yes.
Okay. Takes my monitor a minute to show.
Yep.
Okay, this probably won't be quite as controversial as what we just went through. I'm going to talk about my approach to partly accommodative esotropy with high ACA ratio and give some reasons for it. So when I first went in practice in 1974 until 1980, I used the approach Marshall Parks had advocated, and that basically is to do a medial rectus recession bilaterally for the distance angle and then arbitrarily add 1 millimeter per muscle for the high ACA. He recognized these patients need more surgery than patients with a normal ACA. And when I analyzed my first 90 plus, I actually think it was 99 cases with this approach, I had many undercorrections and I didn't have a single overcorrection. But what to me was most interesting in that is when I looked at the data, I saw that the response at distance was inversely related to the ACA. In other words, if we have two hypothetical patients, case one, 15 at distance, 25 ET at near, the other 15 at distance, and 40 ET at near. Park's formula would have them both get the same amount of surgery, 4.5 millimeter recession. And I found that when I looked at these patients, the ones with the higher ACA got less effect at distance. It's as though the distance deviation its response was related to how high the ACA was. And that led me to realize that the formula we use should consider the amount by which the near exceeds the distance. So I actually did a prospective randomized clinical trial, one group operating for the near angle as measured through distance glasses, not through a bifocal, and compared that to medial rectus recessions for the distance angle plus posterior fixation, which at the time was a popular, still is, but at the time was an increasingly popular operation. And I found that surgery for the near target angle did better in all parameters. By parameters, I mean how their alignment was with glasses, how many got out of a bifocal, and how many of those patients with low plus were able to get out of bifocal. So that was my approach. But then I took that same group and I did a 15-year outcome on them. And I think that's the longest outcome that I can recall from a Strabismus study. And there were 22 patients from this prospective randomized clinical trial that I looked at. 15 years after, 19 of the 22, 86% were no overcorrections and were within 0 to 10 of ET. 13 of the 19 that weren't high hyperopes didn't need glasses to control their esotropia. And all had some sensory fusion. About a fifth had 40 seconds of stereopsis and 63% had up to 200 seconds of stereopsis, and the rest had some fusion on sensory testing. So I think that this group, this approach had longer follow-up and better outcomes than with any other treatment modality that's been proposed. What are the alternatives? As I said, operating for the near angle provided better results with longer follow-up than any other approach. And the three other approaches that are commonly referred to for this entity are medial rectus plus Faden. They didn't do as well. It did better than any of the studies reporting operating for on a formula based on some operating on some of the accommodative element. In other words, in some way taking into account a measurement without glasses or using prism adaptation to determine the dose. And there we have it. Okay, gonna end the show.
Thank you, Bert. Just end the slideshow.
Thanks,
Bert.
Yeah, I'm going to stop
how
sharing.
Interesting that the three of our speakers chose distance near disparity.
Mm-hmm.
Right. I mean, as something to talk about today, I think that's identifying a problem that many people have difficulty with. That's what this comes down to. And I can tell you, I was just checking YouTube and Facebook, and the discussion is so robust, and it's in large part about this and about what we do in strabismus. But so, I mean, Bert, that's what this was, a distance near disparity.
You know, if I, by the way, can you see me? My camera should be on, but I don't see my little thumbnail. So I don't know.
No, we don't. We hear you, but we don't see you.
And my camera's on, so I'm not sure what's going on there. But it's
maybe
okay,
the lights.
You don't need to see me. So what you said reminded me of one of the favorite things that I heard from a colleague, Harley Bicas, who's a strabismologist down in Brazil, said that he views strabismus as a fourth dimension specialty. So the first dimension is a point. We get our primary position measurement. Second dimension is a plane. That's our up, down, right, left measurement. The third dimension is depth. That's our distance near dimension measurement. And what's the fourth dimension? It's time. You got to look at patients over a long period of time. And I think that's very appropriate and relevant to what we've been talking about.
David, I agree with Bert. The accommodative ETs do great as long as you fully correct them. They tend to go undercorrected if you just operate for the small deviation with correction. And I studied this group and what I call augmented surgery versus standard surgery, where you operate for the deviation with correction, the small deviation in the distance. You undercorrect about 25%, and the prism adaptation study showed that. So you just do more. I mean, whatever formula you want to do, you do more. But the high ACA ratio group is tough. Of 40 patients, we had 12 which were high ACA ratio. And I operated for the near measurement. That's what I was taught by Dave Guyton. And in 3 of the 12, I overcorrected distance. And I couldn't even cut the plus to get rid of it. So I think the high ACA ratio patients are a difficult group. The prism adaptation study actually excluded high AC ratio patients because they're the tough group. I don't know why. That's the group you really want to look at. But I think that in terms of just accommodative dystropia in general, they have great fusion potential, and you want to do more surgery than you think you need.
I'm sorry. Can I ask Bert? I don't know. Bert has disappeared.
I don't know where I went. I've lost
Bert,
my
Bert, the people from NTOD who are kind and generous hosts tell us that your webcam is not on.
I know, but I know how to see that, and it tells me that it's on. So I know how to turn the camera on, and I went to the settings, and everything says it's on. But I'll continue to play with it, but I can listen in the meantime.
Okay. So my question is the following. We have in infantile esotropia various 4 types of situation. Fully accommodative esotropia, which is totally corrected by hyperopic glasses, and which generally at the beginning certainly does not need surgery. Then there is the one you discussed is a high ACA ratio situation. Now, here we have to be sure, are we talking of patients who, for distance, with their glasses, have a total parallelism and a perfect binocular vision, and for near have an esotropia, which could be correctable or improved at least with plus glasses? Or have we a combination of situation in which there is a basic deviation plus a high ACA ratio component and so on? Because in my opinion, if this is the case, conflicting results could develop. And finally, this brings also to the fact that you showed that in some cases you did not only a recession of the medial, but also a myopexy, which is in some way translated as father, which I don't like. Is the moment in which you did a recession plus myopexy, you improve the effect of the weakening of whatever position and action of that muscle. So, in my opinion, there are so many elements involved, and I would like from you, if possible, if you are able to, to put them each one on its part, so that we can see what's happening. For me, when I have a high ICA ratio, I consider the patient somebody that, for instance, is totally parallel with binocular vision, motor fusion, and has a deviation from NIA. And on this basis, I can operate at a given age when I'm sure that the bifocal lenses, for example, are not enough. Considering also that a prolonged use of bifocal lenses does disturb accommodation later on in life.
Yeah, I'm not sure if was there a question in that for me. I mean, I agree with what you said.
The question was, were they perfectly straight for distance, and do they have esotropia just for near?
No. So the paper that I had written in the presentation I gave was partly accommodative esotropia. I don't operate on patients that are straight with glasses. These were all patients that had a deviation with their full hyperopic correction of more than 10 prism diopters or more in the distance.
Okay.
Yeah.
So,
Bert,
that raises an issue. Are there people that would? Lionel, hang on one second. I just wanted to say, do people operate on patients who are straight in the distance and have an esotropia at near?
No.
Or do you put them in
No.
bifocals and let them live in bifocals?
Yeah.
But they outgrow the bifocal. I put them in bifocals and they live with it until they outgrow it. They virtually all outgrow it by 18 years of age. Most of them by 13 or 14, but there are some that'll still continue to improve their ACA between 14 and 18. I actually had in my years of practice exactly 2 patients that did not outgrow the need of a bifocal by age 18, and they were going off to college. And I did operate on those 2. But those are really outliers. It's not I don't operate for the purpose of getting rid of a bifocal.
I agree with Bert. I don't operate if they're straight and fusing in the distance. Even if there's a small ESO in the distance, if they're fusing, and usually they're fusing with less than 8 prism diopters, I don't operate.
Bert, I've got 2 questions.
Go ahead.
The first one is the case of a child who is 15 prism diopters for distance and 50 for near. What do you do for that child?
And we're assuming, of course, it's not due to a V pattern or anything like that. It's just a distance.
Correct.
I do my surgery for 50.
50.
Yeah.
Okay.
And I have yet to overcorrect one of these.
Okay. Second question. I thought the Boston Children's paper retrospectively suggesting that bifocals did not improve outcomes in patients with high ACA. In fact, may have led to worse outcomes in high ACA ratio. What do you think of that paper, and would it affect how you treat these patients?
Well, it gave me pause. I respect them a lot, and the study certainly raised some questions. I think before I would alter how I treat patients, I'd want to see something like that replicated. Not to disparage the investigators, but just I think any study that's valid can and should be replicated, because that really could imply a huge change in how we treat an awful lot of patients. So I think the impact of it is great, but it definitely raised my interest. Has it affected your approach, or anybody else's?
I'd like to make a comment, David.
Sure.
Okay, so many years ago, John Pratt Johnson, the late and great John Pratt Johnson, wrote a paper on bifocals, and he had two groups. One group, they were in bifocals, straight in the distance, straight at near. The second group, they were straight in the distance, but they turned in at near, and he didn't give them bifocals. So it was comparing bifocals to non-bifocals in patients with high AC ratio accommodative esotropia who were straight in the distance with their glasses. And guess what? After a 10-year follow-up, after 10 years, both groups had identical stereo acuity, both groups had identical need for surgery, and there was no difference. And so his conclusion, I remember Marshall Parks discussed his paper after he presented it. He says, you know, it doesn't matter if you give bifocals or not, their outcomes at 10 years were the same. So you don't need to give them bifocals. And Marshall Parks gets up and says, John, great paper. He didn't criticize the methods. He didn't criticize that it was not a mass group. He says, great paper. Yeah, they're the same, because as long as they're fusing in the distance, they'll maintain their stereo. You don't need to give bifocals to maintain their stereo. You give them bifocals for the comfort, because who wants to be cross-eyed at near? The kids don't like it. They put their chin up to use their bifocal. So John, you're not giving it to them so they preserve their binocularity. You're giving it to them so they're comfortable at near. So I remember that very well. And I give bifocals for comfort at near. Now, if they have dense amblyopia, it's stupid to give them bifocals. They're not fusing. But if they have fusion potential at near, I give them bifocals for comfort. I'm sorry, Bert, go ahead.
Yeah, no, I very much agree with that. And I'm glad to hear you say that, because I haven't heard anybody else express this idea. It's not solely, if we believe that there's a benefit to having stereopsis, and I think everybody does in this panel, then to say that, okay, at 18 years of age, they're all going to be the same, that means they went from age 5 to 18 without stereopsis because they weren't in a bifocal. If you have one group that's fusing at near with a bifocal and the other's 30 ET at near with a bifocal, it's not just physical comfort. They're not experiencing the benefits of binocularity at near. Yes, they even if his study's correct, and I think it probably was, I don't have any reason to doubt it. Although I question their methodology a little bit, because I think all their outcomes were tested with a synoptophore, which is not, I think, the ideal way to check sensory outcome. But Geraldine Tilson was his co-author on that. But I think that not having the child in a bifocal is depriving them of what we try to give all our patients for all those years until their ACA ratio normalizes. So I agree,
Bert. That's the point. That was the point of Marshall Parks, is you're not giving the bifocals to preserve binocularity in the future. You're giving the bifocals to give them binocular, three-dimensional stereoscopic vision at near. And you know they like it because they put their chin up. Now, if they're not putting their chin up and they're looking over the top, you can say, fine, don't wear the bifocals. I know from John Pratt Johnson, you're still going to preserve your binocularity as long as you're fusing in the distance. But I thought it also represented a nice way to go back and forth very politely, with respect. And I remember so well that great conversation they had in front of everybody on understanding why we're given bifocals. But I also tip my hat to them for the gentlemen that they were and the respect they had for each other.
It's amazing how philosophy.
Yeah,
Go ahead,
in essence, all the statement made cannot be then agreed with. My issue is I have patients who are bifocals only in the moment in which they have asthenopic symptoms. Now, it is, as Ken pointed out, stereopsis, but probably also the fact itself that they have a sensory fusion they have a larger visual field, is something that they look for. And I agree that they elevate their chin in order to do better. In this patient, I do prescribe bifocals. Now, what to do late? In the other ones in which there is no symptom whatsoever, I don't see any reason why to prescribe bifocals. Now, what to do next in this patient? There are those who luckily have slowly can wind out from the bifocals. They don't need anything, but there are very few that I had to operate on, not early, 15, 16 years, a moment in which they really could not tolerate bifocals, and on the other hand, they had a really problem in their daily life. So that's my attitude for those. Very often, it's interesting is this that in these patients who for near originally were totally straight, with the change of life, changed a little bit hyperopia, which was reduced. And therefore, their glasses, the full correction had to be reduced. And these patients started to have symptoms also for distance. So that, in conclusion, I agree. You cannot just operate on this patient and have them wear bifocals for nothing. They have to have an advantage.
Points with this that I think that I do in my practice based on my opticianry background. The first is I don't use executives. D25s, 38s, or 35s are good to start in. And if the patients adapt to the bifocal and use their chin up, I switch them to progressive addition. That sometimes starts playground fights. You know, why do you have that line in your glasses? So I get them out of the adapted of and drop their eyes and raise their head. And they even learn how to computers and their tablets. I don't see the anecdotal, my mentor did it this way, executive lens. I think that there's not some truth to that. I always tell the story of my great Italian grandmother baking the meatloaf in 2 pans. And for generations, all my family baked meatloaf in 2 pans. It was because my great-great-grandmother had a small oven in Italy and had to use 2 pans to feed the whole family. You know, that's why she did it.
Rich, I agree with you. I've been advocating against the executive bifocal for at least 25 years. When a patient brought in 2 pairs of glasses with the identical prescription, one executive, one with a DSEG, and the executive lens was double the thickness and
Right.
double the weight.
Right.
This was a moderate hyperope, 5-6 diopters. A flat top DSEG is far more acceptable.
Rich, are you there, Rich?
Yeah.
My grandmother made me brajola, and I can't find it here, so I ended up making it myself. But Rich, did you do a prospective randomized mass study on your executive versus your bifocal, your
Base validity?
Bifocal case validity. You're joining me.
Base validity.
Well,
Parachute.
Thank you. That's you're joining me, Rich. Thank you.
And you and I are going to go skydiving. We're going to go skydiving together, Ken. I'm taking the parachute. You don't take the parachute.
I mean, obviously, this is a group of people that feel very passionately.
Yeah,
Rich,
actually, I'm going in an hour.
Yeah, golf is for people who can't surf.
Ooh. Well, you know, I was thinking when we did the introductions that, Ken, you like your water in the liquid state, and Rich likes his water in the frozen state because he skates on top of it with blades, and you surf on top of it. So you both end up moving on top of water in different states.
David,
so
we all think we walk on water, don't we?
The ultimate perfect. That was perfect.
Yes, I like Bert's conclusion there.
Yes.
That everybody thinks they walk on water. So, well, we're gonna have to wrap up, and I thought of 2 things. First was a quote from, or a comment from Kurt Vonnegut's book, The Sirens of Titan, where he describes the chronosynclastic infundibulum, if I remember it correctly. And the explanation is, if you're a child, imagine your daddy's the smartest person in the entire world, and is never wrong. And you meet a child from another planet, and his father is the smartest person in that world and never wrong. And the two daddies meet and they don't agree. So that's what this sort of feels like, is that we have experts who are brilliant at what they do and have differing approaches to the similar problems. And the other, what I thought of was, and I hope he doesn't mind me saying this, rest his soul, but Von Norden, when I was a fellow, came and spoke at the Children's Hospital of Philadelphia. And I was the one assigned to drive him around. And I asked him what his favorite meeting was. And he named one. And I said, why? And he said, because over a glass of wine afterwards, we all get together and admit what we don't know. I like the honesty and the openness of this group, and I want to thank you. Irene, do you have anything you want to wrap up before I go through some of the housekeeping things we have to do?
Well, I would like to thank everybody. It was fantastic discussion, really nice, and yeah, it's really nice to see the different opinions and where we are in strabismus and what we don't know. That's the main thing that comes out. Thank you.
Yeah, and I'll add to that. Thank you for on behalf of all of us here. We know that the passion that came through today was related to how much we all love this topic and the respect that we all have for each other, of course, shows as well. Education is the most powerful weapon which you can use to change the world, Nelson Mandela. And that's the purpose of WSPOS. And all of you today contribute to that education and the work you have done all around the world. The number of children and adults you have touched, I get to be the one to say thank you on their behalf. And I'm thrilled to do so because you have made such a difference. Once again, for anyone listening, participation certificates can be gotten by emailing program@wspos.org. This is one world, one love, and one community that we share. And all the speakers here haven't seen it, but the discussion online around the world was incredibly robust. For those of you who want to talk more about individual topics, our grand rounds yesterday, for example, that you can find online that we do so often, drill down to the individual patient. We have a whole series of more talks coming up in the webinars. We'll be talking everything imaginable about specific topics. Today was a 30,000-foot view with some granularity to it as well. There's experts talking about not only the details of strabismus, but the philosophy that underlines our approach to taking care of the patient. Please remember to join us at WSPOS. Membership is free. There's no reason not to join. And you can find all those details at WSPOS.org. You can join the Facebook page and the group where it's really robust with lots of discussion going on. Subscribe to the YouTube channel. I've run the listserv for pediatric ophthalmology and strabismus since 1994. Email me, and if I don't know you, please just let me know where you've done your training and where you're currently working so I can add you to the group. And you can join the 1,600 doctors around the world who are constantly discussing cases. My heartfelt thanks goes out to Irene Gottlob for her efforts in making sure this went well. And to our speakers, again, in the order they spoke, Ken Wright, to Emilio Campos, Lionel Colville, to Rich Hurdle and Bert Kushner. My deepest thank you for all of your efforts and work. You were all amazing and in some way mentors to me in my lifetime, and on a personal level, on a professional level. Thank you all. Thank you to NTOD, our hosts, for being such wonderful hosts for all of these webinars. Thank you to all of the people at WSPOS, our administration. Dara, thank you. Akila, thank you as well. And for those of you who don't know Akila, she is the force behind making sure these all go well, and an incredible sitar player who we all heard magically lift us at the WSPOS World Congress in Hyderabad. We look forward to seeing you for our next webinar. And once again, thank you. For those of you who missed any of this, please log on to our YouTube channel. You can watch this all over again. And for the panel, I believe we were into the deep several thousands of people around the world who joined us today watching. Thank you again.
Your child,
And
imagine your
have a
dad,
great
he's
rest
the
of your
smartest
day
person.
or afternoon or evening or sleep wherever you are in the world. Thanks again.
Thank you, David. Thank you.
Thank you, David.
Thank
Thank you, Harry. Wonderful.